Hello, Assalamu alaikum. It's me, Dr. Muhammad Naseem Shirzad, and I am recording this video for FCPS Part 1 candidates, and they requested to explain in simple word the adrenal gland and the relevant question asked in CPSP exam. So, whenever we are trying to understand the MCQ, we need to understand fully the topic. After that, we will be going toward the MCQ. So number first, let's discuss the anatomy. So the adrenal gland, as we are saying that these are pair organ, means there are two, one on right and one on left side. Uh, the adrenal gland is located at the upper pole. This is the gland which is located at the upper pole, and it is located on the medial aspect. So upper pole, medial aspect, this is the location of the adrenal gland. And we also know that the kidney as a whole is located in the retroperitoneal space. So if kidney is located in the retroperitoneal space, retroperitoneal mean outside the peritoneum, right? So if kidney is located outside the peritoneum, means the adrenal gland will also be outside of the peritoneum, means a retroperitoneal organ. Regarding the separation from the kidney, so the adrenal gland is separated from the kidney just by perinephric or perirenal pairs. There is only presence of pairs between the adrenal gland, which we also call suprarenal gland. Supra means above, so it's above the kidney. That's why we also call it suprarenal gland. So don't confuse it. Now regarding the shape of the right side is actually, if you look, this is pyramidal in shape, but the left side is crescenteric in shape. The comparison of size of kidney with adrenal gland, the fetal gland is one third size of the kidney. Now its the location or the histological detail of this adrenal gland is important. It is divided into cortex and medulla, and both have different embryonic origin. So what are that embryonic origin? So these questions should arise in your mind when you are studying, and I have given that on next page, that the cortex is from mesoderm, while the medulla is derived from the neural crust cell. Number second, that there are preganglionic sympathetic fiber which are derived from the greater splanchnic nerves, and that is supplying the medulla. That's supplying the medulla, not the cortex. This is important. That's why when we are talking about the medulla, means we are talking about the catecholamines. We will go into detail on next page. So it's contain a nicotinic receptor and having a dual nature, like it is acting itself as endocrine gland, and it also receiving a sympathetic ganglion for sympathetic nervous system. So now let's discuss the cortical and medulla portion of this adrenal gland. So the adrenal cortex, which is the outer portion, and it is outer yellowish portion, and it form 80%, means it make a very major portion of the adrenal gland. The adrenal medulla, which is in a reddish or brown portion, and it form just 20% of the adrenal gland. We have already discussed this embryological origin. Now the adrenal cortex, it is a adult zone, means it's starting its function in adult zone, while this is called the fetal zone. Now coming into what the layer of the adrenal cortex, and I have given just a mnemonic for easy understanding, and that is GFR. GFR mean glomerulosa. The second is the fasciculata, and the third is the reticularis. So again, the division is important. Like the glomerulosa is just forming the um, 15%, while the fasciculata form 85%, while the reticularis forming 5 to 7%. So this forming 15%, fasciculata 85%, and this is just 5 to 7% reticularis. So this understanding of this is also important. And cortisol is produced by almost all three layers. This is also asked multiple time in a question. So glomerulosa can easily be remembered by that GFR, which is corresponding with the salt, means that is the aldosterone. Like for example, zona glomerulosa, and that is producing the mineralocorticoid. When we are saying mineralocorticoid, means that is aldosterone. The second is the fasciculata, which I already said that it's formed around 85 or 75% of the total cortex. That's why it is the thickest portion. Can be asked in a questions. And it produce corticosteroids such as cortisol, and it also produce a small amount of androgen. Androgen means testosterone, right? Like 90% of the testosterone is produced by the testy, but the 10% of testosterone is also produced by the spiciculata. Now coming toward the reticularis, and that is it produce and secrete androgens such as dihydroprogesterone, and it also secrete a small amount of corticosteroid. As I have also mentioned that GFR is corresponding with the salt. For easy understanding, that is mm, uh, means glomerulosyldirone. For pesiculata, that is sugar, and for the reticularis, that is the androgen. And the deeper you go, the sweetest it get. One thing which I want to highlight in this uh, uh, table, that this zona glomerulosa is not under control of ECTH. It is a control of the peripheral presence of potassium and NaCl. So it is not under control of ACTH. That's why if someone lost pituitary gland, there will be no effect on this glomerulosa, right? So that's why the destruction of the anterior pituitary gland causes decreased function of the zona pesiculata, right? So it's affect pesiculata, but it's not affecting the glomerulosa because the aldosterone is not under control of ACTH. This point is very important. Now coming in toward the adrenal medulla. So the inner reddish brown portion, 20% fetal zone. So regarding the hormonal changes, they have containing chromatin cell, and this chromatin cell having granules which containing the noradrenaline, means the norepinephrine, and adrenaline, which is the epinephrine, and it make 80%. And these hormone, you know, that's important for fight or flight, means sympathetic nervous system. One question was also that chromatin is secreting enkephalin, which is the which function to control the pain. Now let's discuss the nerve supply of the adrenal gland. The adrenal gland, we know that is innervated by the celiac plexus and the greater splanchnic nerves, and it is also supplied by the sympathetic nerve, and that is actually supplying the adrenal medulla, and that is why the myelinated presynaptic fibers, and that is from the portion of spinal cord which is T10 to L1 spinal segment, and it end on the nicotinic receptor in the medulla. The blood supply of the adrenal gland is by numerous artery, I means which are directly from the aorta, that is inferior phrenic artery, renal artery, and by a single vein. So this was a question in which they were asking which one of the following is correct. So correct is that it is supplied by the numerous artery but drained by the single renal vein. And I have written some important clinical point on adrenal medulla, like if we go for adrenalectomy of a patient, so the norepinephrine will remain unchanged due to the production from that presynaptic ganglion, while the epinephrine will reach to zero. The second important thing is that after adrenalectomy there will be increased in the threshold for salt sensation, because if there is a loss of adrenal, there will be loss of aldosterone, and when there is a loss of aldosterone, there will be no absorption of actually that of NaCl, because we know that aldosterone is actually a potassium loser and NaCl absorber. The second important thing is if we go for adrenalectomy of a patient, so what's the protocol of steroid replacement therapy? So the steroid replacement therapy after adrenalectomy should be reserved only for those patients with Cushing syndrome, means those with the overt or a clinical, and those patients who are going for bilateral adrenalectomy. So for bilateral adrenalectomy and those with Cushing syndrome, these patients will be in need of steroid replacement therapy lifelong. Another important things uh, regarding the protection and life-saving hormone. Actually, NCPSP, they are just twisting the word, which may be very usual and very common for you, but that make a big difference. Like if they ask which one of the following is life saving, so life saving is actually cortisol, aldosterone. Sorry, aldosterone is a life saving. Reason is that because that's potassium is life saving, that's absorption of sodium chloride is important, because if there is no sodium chloride there will be circulatory collapse and that's leading to death. While the cortisol absence is important, its presence is important, is a protecting hormone because it protects us from a stress, it protects us from a trauma. So this just give a protection to us. But if you want to save the life, that will be aldosterone. The next is the cachexia is not a feature of hypopituitarism. This is actually basic news. As I have mentioned that all three cortical zones secrete steroid, and the cortisol or hydrocortisone is a more potent, and it is a 95% of glucocorticoid activity. Number second, it is short acting and it is having a high sodium retaining potency. If we compare this with the dexamethasone, it is a long acting, it having anti-inflammatory potency and immunosuppressive effect, but having no sodium retaining potency. So this differentiation is important. You can review this steroids like dexamethasone and aldosterone and that's of prednisolone in a detail, because they are asking a question like they can ask you that if a patient is using some steroid spray, oral spray, what he can do. So he need daily oral resin or oral washing, because dexamethasone oral can cause oral ulcer. That's why it's frequently advised to go for oral wash with resin. So this is important. As I have mentioned that glucocorticosteroid is important. If you just understood the physiology of this steroid, you will easily understand that all other pathological condition, like what's its normal function in a body. So its one function is that it stimulates the gluconeogenesis. This is also MCQs, and this causes the degradation of lipids and protein, but it prevent glucose utilization by the tissue. This is another MCQ. What its anti-inflammatory action and action on a blood cells. So it inhibits interleukin 2 and it decreases level of eosinophil, basophil and lymphocyte. But on the other end, it can increase the circulatory level of neutrophil, RBC, platelets. It inhibits the T lymphocyte proliferation. That's why steroid is a very cornerstone treatment for a patient of renal transplant and other condition, because it's immunosuppressant. We gave it as immunosuppressant. And acute rejection, we gave it in a bolus for 3 days because it is an immunosuppressant. The other function that it causes the upregulation of alpha 1 receptor in blood vessels, so it leading into the vasoconstriction and leading to increase in BP. So one thing another clear that it can cause hypertension. Also note that thyroid hormone increase the sensitivity of beta 1 receptor. We have already have a command of it that a patient of hyperthyroidism is always having palpitation and tachycardia because of this increased sensitivity of beta 1. So this is MCQ, that's why I have mentioned it here. Another is that it steroid cause inhibition of wound contraction, means delay the wound healing. It inhibit the fibroblast, and that's why it's cause tria. We will discuss that in later because there is MCQ on it. It inhibits osteoblast, not osteoclast, which I have corrected in a 7th edition, and that's lead into osteoporosis and osteopenia. So if you look into just into your clinical practice, if a patient has on prolonged steroid, he will be suffering from oral thrush, he will be prone to infection, he will be uh, can suffer from osteoporosis, he can be in a stage of immunosuppressant, he prone to infection. This is the mechanism of action of steroid, because they are asking in a question which I have already explained, so I don't want to go in a detail of it. So, after detailed anatomy, physiology, now we are coming into the pathological aspect of adrenal gland. So, your study methodology should be like this, like in a modular form. You need to understand the anatomy, histology, pathology, embryology, and pharmacology. And after covering of this with the good concept, go for MCQ. And those MCQ which are easy and you can solve on the basis of theory, that's well and good. Those which you are unable to solve, put a star on that and revise the topic again. If I have not written that properly, review that from some other textbook like BRS, like Guyton, and add that point on that topic. If you still unable to solve, put double star on that and share with us in a group and we will respond to them. Now, the disease of adrenal gland, I have divided into two parts. Either the adrenal gland will be hyperfunctioning, means everything will be releasing, aldosterone will be releasing, steroid will be releasing. The second arms of this disease can be hypofunctioning, means the adrenal gland is not working, the disease which causing the uh, adrenal gland to stop production of aldosterone steroid. So these are broadly divided into the hyperfunctioning of the adrenal gland and the hypofunctioning of the adrenal gland, and specifically only regarding the cortex, the portion of the adrenal gland which we call the cortex. The disease of the cortex is divided into hyperfunctioning and hypofunctioning. And this is I have written in my own style. Like this was very easy for me to correlate the things. Like for hyperfunctioning, I was always uh, remembering and revising this sentence in my mind, that when there is a hyperfunctioning of the adrenal gland, there will be hypokalemia. Because why hypokalemia? Because there is excessive aldosterone, and you know that aldosterone is a potassium loser. So if it lost potassium, it will cause hypokalemia. And remember one sentence for life: when there is a metabolic alkalosis, there will be hypokalemia. So these both will be going side by side. When you see metabolic alkalosis, there should be no hyperkalemia, it should be a hypokalemia, right? Number second is hypertension and hypernatremia. So you know that if there is excessive aldosterone, it will absorb a lot of sodium, NaCl. So if it absorbs a lot of sodium, it will cause hypernatremia, and when it causes hypernatremia, that's will leading into hypertension. So hypernatremia will always be with hypertension. Now you can make them opposite in case of adrenal insufficiency or hypofunctioning of the adrenal gland. So this is one of the easiest way to understand the hyperfunctioning and hypofunctioning. Now, what are those diseases which can lead into a hyperfunctioning of the adrenal gland? So one is a Cushing and the other is the aldosteronism. Like there are three layers which we have discussed. If there is a problem regarding the steroid, like the fasciculata, so this will lead into Cushing syndrome. The other is the one which is the glomerulosa, and if it is hyper, it will be causing increase or excessive secretion of aldosterone. So only two diseases we need to remember. One is the Cushing and the other is the hyperaldosteronism, right? We also call it as a cone disease, right? So for Cushing syndrome, don't confuse Cushing disease with a Cushing syndrome. So there are two causes of the Cushing syndrome. One is the exogenous and the other is the endogenous. The exogenous, the one which I have talked, that is the iatrogenic Cushing syndrome. And this is one of the commonest cause of Cushing syndrome, like the administration of the glucocorticosteroid, and those hakim which are giving that for various conditions. These excessive steroid can lead into renal failure because they're giving a lot of steroid. Because you know, when you have a pain and you visit into a local GP, they will be giving you some injection for quick relief of a pain or some other condition, because it's some life saving, life uh, protecting hormone. So that's why it is using by the Hakim because it gave very quick response, but they don't know the osteoporosis, the oral thrush, the immunosuppressant, and multiple problem which is caused by this and renal failure, which we have seen the patient which were on lifelong um, Hakimi dawai that's containing steroid that's leading to renal failure. So the other is the endogenous cause, means internal problem, and the internal problem can be Cushing disease, which is 70%, means very common. So the Cushing syndrome, that is secondary. If there is a problem in a, to make it very simple, a problem with the pituitary gland, then we call it as a Cushing syndrome. So Cushing syndrome is secondary to pituitary tumor. Cushing syndrome secondary to pituitary tumor is called Cushing disease. So to make it simple, if there is a problem in a pituitary tumor gland, we call it a Cushing disease. If there is other aspect like iatrogenic, like many other condition, like syndromic feature, we will be calling it the Cushing syndrome. The other cause of endogenous is the adrenal tumor, that is the adenoma, which is the most common cause of excessive endogenous steroid production. Other conditions include ectopic ACTH production, that is 15%, and that includes small cell carcinoma of the lung, which is the most common cause. Now coming into the clinical picture, how this Cushing syndrome patient can present. So these least, most specific, more specific, non-specific, these all are important because they have asked in a question which one is more specific, which one is least most specific, and one which one is a non-specific feature. So there is no need of explanation. You need to rata, understand, and revise it again and again. But there was a question that why this purple striae occur on the abdomen because of this Cushing syndrome. So this is because of deficiency of collagen fiber due to protein depletion, and that's leading into thinning of the skin. That's why they have asked in a question, and you need to understand it. The second is the hyperaldosteronism, and we know when there is a hyperaldosteronism, that will be excessive secretion of aldosterone. One is a primary and the other is secondary. Primary, there will be high aldosterone, but renin will be low, and the causes include aldosterone secreting adenoma, which we also call as the Cone syndrome, adrenocortical carcinoma. We saying it adrenal, adrenocortical, not adrenomedulla. That's why I'm saying that we are discussing the hyperfunctioning and hypofunctioning of the cortex, not the medulla, right? The second is the secondary hyperaldosteronism, in which there will be high aldosterone and a high renin, and the causes include renal artery stenosis, congestive cardiac failure, cirrhosis, and nephrotic syndrome of pregnancy. So this was some detail, and if you want, and if there is any question more in detail, you can review it from some other textbook. But as this is a high yield, and it covered all the relevant information. Now coming to the other arm or other aspect of this adrenal cortex problems, and that is the uh, adrenal insufficiency, means hypofunctioning, and we divided it into two. One is the primary and the other is the secondary. The primary, there is a decrease in cortisol or aldosterone, and there will be increase in ACTH level. So one difference, when there is a problem in primary condition, ACTH will be high. As I have mentioned earlier, that aldosterone is actually not in a control of ACTH. So per differentiation of primary and secondary, in one there will be increased ACTH, but on the other hand there will be decreased ACTH. So per primary there are two types. One is acute and the other is a chronic. The acute condition is Waterhouse-Friderichsen syndrome, which is due to adrenal hemorrhage, and one I think so with meningitis is also, which is also called Waterhouse-Friderichsen syndrome, and that's an acute condition, and that's the hypofunctioning of the adrenal medulla. There will be no aldosterone. The chronic condition is the Addison disease, and the two most common causes is the tuberculosis in a developing country and autoimmune adrenalitis in developed country. This is important. This developing and this developing country. For example, Pakistan is a developing country, and Europe, etc. That is developed countries. So in Pakistan, that's why tuberculosis is common. So this differentiation is important. The secondary adrenal insufficiency, it is the most common cause of adrenal insufficiency. So one thing clear, among primary and secondary, the secondary is the commonest one. But there will be decreased cortisol and testosterone associated with decreased ACTH level. And this can be caused by the rapid withdrawal of long-term glucocorticoid therapy. This is the commonest cause. And maybe pituitary tumor, hypothalamic disease. It means there is a problem in the brain, right? To make it simple, because there is no ACTH from the brain. So if there is no ACTH from the brain, we label all those diseases a pituitary or hypothalamic disease. What are the clinical falls? I have written this clinical falls to differentiate clinically between the primary and secondary, and that can be differentiated by this just ACTH, high ACTH, low ACTH, and this can give a skin hyperpigmentation. So this concept is important. Now the only and the last is the peuchromocytoma, and the peuchromocytoma is disease of medulla. This is a single disease which we will discuss at the peuchromocytoma, and this is the disease of the medulla. So it has a rule of 10, and this rule of 10 is important. And 10% familial, 10% malignant. It means 90% peuchromocytoma is a benign tumor. So they can trust the word. You need to have very clear in your mind. 10% is bilateral, 10% in childhood, and 10% can be extraadrenal, means the peuchromocytoma can occur in other part of the body like aortic bifurcation, carotid body, posterior mediastinum. And the presentation can be remembered by 5 P's, that is the blood pressure, hypertension, this is one of the hallmark. The other is the pain. Pain means there will be headache, they can cause chest pain, this will cause tachycardia, tremor, weight loss, and fever. You know, all these related with adrenaline. Epinephrine, if there is epinephrine, this will cause vasoconstriction. When there is a vasoconstriction, this will also cause activate the mm, beta receptor. It will lead into tachycardia, and it's lead to tremor, weight loss. So the understanding of this physiology is important. Is cause profuse sweating, right? And the investigation, the gold standard is the increased 24-hour urinary metanephrine, which is actually a metabolite of catecholamine, so don't confuse it. The plasma catecholamine is having highest sensitivity, that is 96%. CT-MRI is a first-line treatment for localization of adrenal tumor and sympathetic chain tumor, right? But for a tumor which is an extra-adrenal, like in chest, like in bifurcation of aorta, for that, if not detected by CT or MRI, we will be going for MIBG, right? And peuchromocytoma, remember one word for peuchromocytoma, it is a surgical disease, it's not a medical disease. I means you can't leave a patient lifelong for medical treatment. Once diagnosed, it should be removed. And the gold standard treatment is laparoscopic adrenalectomy, right? But before starting going for surgical procedure, you need to start patient on an alpha blocker 2 weeks before the procedure. And alpha blocker, you can give penoxybenzamine, and that is 10 milligram BD for 2 weeks. And in entrop condition, we will go for propranolol, which is alpha blocker, and it is given entrop in order to prevent the reflex tachycardia, which is caused by the alpha blocker, right? So beta block should not be introduced until the patient is alpha block. That's why I'm saying that 2 weeks before the surgical procedure, you are planning give alpha blocker, and after that, during surgery, go for beta blocker. And as I said, that it's a life-threatening condition, it will lead to death. That's why surgical disease, not a medical disease, and it should be removed as soon as possible. And this is diabetes insipidus, which is an easy topic, can be a problem in a brain or a problem in a kidney. If a problem in a brain, there will be no ADH. If a problem in a kidney, ADH will be high, but the collecting tubule will not be responding to ADH. It's not a part of adrenal, so you can revise it from MNS.